Good morning, everyone. I see that we've got our attendees joining us now. So a warm welcome on a warm, at least in Hamilton, Wednesday, February 16th, 2022. It is my pleasure to welcome you today. Welcome to today's webinar, Easing Pandemic Restrictions in Long-Term Care. I'm Sam Peck. I'm the Executive Director of Family Councils Ontario, and I'm so glad that you can join us for today's important learning opportunity. As the pandemic is ever changing, so are the scientific knowledge and the measures put in place to respond to the pandemic and its impacts. We know that the last 2 years, can you believe it's been almost 2 years, have been incredibly tough on long-term care residents, family and friend caregivers, and staff. Some days it feels like things are changing from day to day. Today's Easing Pandemic Restrictions in Long-Term Care webinar with guest speakers from the Ministry of Long-Term Care and Office of the Chief Medical Officer of Health will bring you up to date on these changing restrictions and how the restrictions will be eased in the coming weeks. As caregivers, we know how important it is for you to receive these updates and for the Ministry and Office of the Chief Medical Officer of Health to hear your questions and concerns directly from you. You'll have an opportunity at the end of the presentation to ask your questions. The panelist presenters will let you know how to do so. Before I turn it over to our guests, let's start with a land acknowledgement. Family Councils Ontario was founded on land, Toronto, that is the traditional territory of nations including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Like the rest of Ontario, it is still home to many diverse First Nations, Inuit, and Métis people. As a remote team, and as many of us in different organizations are working from home these days, we encourage our team members, our service users, our partners to reflect on colonialism's enduring legacy, its impacts, and to engage in reconciliation meaningfully. We encourage everyone to find out more about the land they're on. You can use whose.land or just Google whose land to learn more about the territory, peoples, and languages they speak of where your home is situated. The work that non-Indigenous organizations and individuals need to do towards reconciliation with Indigenous peoples is a long-term journey. It's specific to each individual and organization, and it's also constantly evolving for our organization. And we hope you will join us on this journey. Now it is my pleasure to turn it over to Erin Hanna, Associate Deputy Minister, Long-Term Care Pandemic Response, for opening remarks. Over to you, Erin.
Thanks so much, Sam. Good morning, everyone. It's a pleasure to be here today. We are, along with my colleagues, both from the Ministry of Long-Term Care and the Office of the Chief Medical Officer of Health, really excited about this opportunity. And this is the first family-oriented webinar that we have mounted, and I really plan for this not to be the last. We'd like to use this as a learning opportunity for ourselves as well on how we improve our communication channels and our opportunity to engage more directly with family members so that we can apply your experiences and your input to decisions as we go forward to improve the long-term care system in Ontario. Sam noted that our focus today is really on making sure that there's a strong understanding of the changes that have been mapped out, both with respect to easing the temporary enhanced measures that were put in place in December of 2021, specifically in response to the Omicron wave, as well as changes that have been made by the Office of the Chief Medical Officer of Health to the guidance that's provided to public health units across the province to support long-term care homes and retirement homes in the management of outbreaks with respect to COVID-19, and how those changes hopefully will have a positive impact in terms of supporting a better quality of life for residents within long-term care homes, particularly with respect to the isolation requirements that are connected to COVID-19 outbreak management and the testing requirements. There'll be an opportunity, as Sam noted, for questions and answers at the tail end of the session today following the presenters. And so without further ado, I'm going to introduce Erin Mannix, who's a member of our pandemic response team at the Ministry of Long-Term Care. Thanks so much, Erin.
Thanks, Erin. As Erin said, thank you everybody for having us today. Just a little bit of housekeeping at the start. I see there's been some questions in the chat right now. So our Q&A today will be facilitated via the website Slido. So as you can see on your screen there, and I believe my colleague is going to post a link in the chat, but you can go to slido.com or www.sli.do, and then the code for today's webinar is FCO Feb 16, and that's where you can enter your questions that we will be addressing at the end of the presentation. So with the amount of participants today and the time we have allotted for questions, we will only be answering questions that are relative to the sectors and addressing the topics covered today. So in regards to the confirmed outbreak definition, managing contacts in long-term care homes, as well as admissions and transfers. Next slide, please. So this slide is just an evolution of the ministry's temporary enhanced measures that we had seen implemented over the time span of Wave 5 in order to provide optimal safety for residents and staff that provide care within the homes, based on the advice of the Office of the Chief Medical Officer of Health. So just for your reference, noting the acronyms in the bottom right corner, GV refers to general visitor, and then SSV refers to staff, students, and volunteers. So an overview of this slide: before the Omicron variant, there was no limit to caregivers and general visitors, no restrictions on social absences, and fully vaccinated individuals were exempt from surveillance testing. And for those who aren't aware, that's the testing conducted prior to individuals entering the home. In mid-December, the immunization policy came into effect, requiring general visitors to be fully vaccinated to visit indoors, and a maximum of 2 people for indoor visits and 4 people for outdoor visits. Over this time, we increased surveillance testing and efforts to identify any positive COVID cases and stop them from entering the homes. By the end of December, the province saw a large increase in Omicron cases, resulting in access being paused for general visitors and social day absences being paused. It's also important to note that during this time, caregivers and general visitors were able to visit residents receiving end-of-life care regardless of their vaccination status, and that all essential medical and compassionate day absences were still permitted. Next slide, please. So the easing of temporary measures, I'm just going to walk you through this chart here. Currently in place, that came into effect February 7th, general visitors are still paused. On February 21st, we will see them, the number increasing to 3 visitors allowed at a time, including caregivers per resident, and visitors ages 5+ must have 2 vaccine doses in order to enter the home. Gearing up towards March 14th, we will have 4 visitors permitted entry into the home, including caregivers, at a time per resident, and children under 5 may begin to visit with no vaccination required. So for essential caregivers right now, the policy that came into effect February 7th is that 2 caregivers may visit at a time. Unless the home is in outbreak or isolation, then that goes down to 1, and up to 4 designated caregivers per resident. That's an increase unless those caregivers were designated prior to December 15th. On February 21st, similar to the general visitors rule, 3 visitors at a time per resident, including caregivers. And then March 14th, there will be 4 visitors at a time per resident. In regards to social absences, so we saw the resumption of social day absences for residents who have at least 3 doses. And on February 21st, social day absences are returned for all residents, regardless of vaccination status, and the resumption of social overnight absences for residents who have at least 3 doses. By March 14th, all social overnight absences will be allowed for all residents, regardless of their vaccination status. And on the next slide, we have a reminder of resident safety in the community. So whenever outside the home on an absence, it's really important that residents do their best to wear a mask as tolerated, wash hands frequently, limit their contacts with others, avoid crowds, large social gatherings, and gatherings with unvaccinated individuals. They need to also physically distance and try to only be in close contact with fully vaccinated people, especially when eating or singing. And these are just reminders to help reduce transmissibility of the virus and exposure for residents. With that being said, I'm going to pass it over to Dr. Sarah Erdman and Danielle Reimer with the Office of the Chief Medical Officer of Health.
Hi, everyone. I just wanted to recognize that the past several months have been some of the most difficult and challenging of the pandemic for residents and their families. The public health measures that were put in place at the beginning of the Omicron surge in December were done so out of an abundance of caution to protect residents from a variant that was more transmissible. And at the time, little was known about how much protection vaccines would offer for those who are most at risk for severe outcomes from COVID-19. That being said, we recognize how challenging the prolonged isolation in homes that have had outbreaks has been for residents and their families. And so we've made recent changes to contact management and outbreak guidance provided to the public health units with the goal of having outbreak management measures that prevent and mitigate the risk of uncontrolled spread of COVID-19 while trying to balance residents' needs for social interaction and emotional and physical support. That being said, public health units continue to have the discretion to modify or discontinue activities within the home as part of their outbreak investigation and management. And so they're really in charge when they are with respect to implementation of measures to reduce disease transmission within the home. However, the guidance provided to them is an attempt to have some provincial consistency and again, to balance residents' needs with the goal of outbreak management as well. So next slide, please. So I'm just gonna cover some of the highlights for the changes to outbreak management. So we're really promoting that public health units allow activities while cohorting during outbreak management. At the discretion of the public health unit and when feasible for the home to implement, group activities, dining, and other social gatherings may continue or resume in areas of the home that have not been affected by the outbreak. Gatherings and group activities within the outbreak area of the home may continue and resume for specific cohorts as advised by the public health unit. And certain activities for residents that are in isolation may continue or resume. And those could include supervised and scheduled walks one-on-one with a caregiver or with a staff when both are wearing appropriate PPE or masks, and supervised and scheduled outdoor time when weather permitting with IPAC measures in place. Next slide, please. And so contact management. So contact management decisions are again made by the local public health unit. Next slide, please. So I'll go into a little bit about what changes have been made to the guidance for public health units. So we've added a category for lower risk contacts, and those include residents who are fully vaccinated and boosted with their third or fourth dose of the COVID-19 vaccine, and they were in contact with someone, but it was deemed to be of a lower risk nature. And so I'll go into a little bit about that on the next slide. High risk contacts, there is a similar definition from before, and public health units conduct a risk assessment and decide what exposure might be high risk or lower risk, depending on the nature of the interaction and the accumulated contact time, for example, that a resident might have had with a positive individual. Next slide, please. So for example, lower risk exposures might include receiving care from a staff member who was positive with COVID-19, but who wore a mask consistently and appropriately. And we feel like that change will hopefully address some of the isolation that residents have been experiencing when there's staff cases and they've been a contact of that staff, but have been vaccinated and boosted, and the staff was wearing appropriate masking when they were providing care to the resident. And so those residents would only have to monitor for symptoms. We advise that they have a PCR test taken on or after day 5, but isolation would not be required. So that's one example of the measures that we're trying to put in place to reduce resident isolation. Residents who have higher risk contacts as determined by the public health unit, those who are fully vaccinated and boosted with their third or fourth dose, which is the majority of our residents in long-term care. Again, we're trying to reduce the burden of isolation on residents by having them isolate until after a day 5 PCR test is received, provided that they remain free of symptoms and that test is negative. So trying to reduce the days spent in isolation. Next slide, please. And so I'm going to hand it over to my colleague Danielle to walk through some of the scenarios.
Hi everyone, and thank you all for joining. Unfortunately, my video has a mind of its own, so it won't go on for me. So I am just going to run through some scenarios to provide examples that Sarah went over in the changes to our guidance. So in this scenario, a staff becomes symptomatic and tests positive for COVID-19. They had provided direct care to residents for 2 days prior to their onset of symptoms. So this is during their period of communicability. So some of the questions that the home or the health unit may ask, we've included in a nice little flow chart here so that health units, homes are on the same page when it comes to treating contacts and how they're handled. So if we go through starting at the top, was the resident in contact with a positive case during their period of communicability? So we could answer yes there. Thank you. And then did the resident receive care from a healthcare worker who was positive for COVID-19? And the answer again would be yes. Did the healthcare worker have consistent and appropriate use of masking? So this would be something that would be investigated by the health unit and on the home. So in this case, it is determined that yes, the healthcare worker did have appropriate and consistent use of masking. And then was the resident vaccinated and boosted? So the answer here, the majority of them I would imagine would be yes. So then they would be treated as lower risk contacts. And in that case, they would need to be monitored for symptoms with a PCR taken on or after day 5. And then isolation would not be required unless symptoms develop or a positive test result. And you can see in that last question, you can also go to no, and then they would be treated as a higher risk contact. So in the next scenario, we have a resident that has a day visit with a family member. And that evening, the resident attends a communal dining with his or her dining cohort, comprised of 5 residents from their 30 resident unit or floor. The following day, the resident develops symptoms and tests positive for COVID-19. So a common question are what happens to the residents that are in the same dining cohort? So we can go through the same flow chart and answer similar questions. So again, was the resident in contact with a positive case during their period of communicability? So those 5 would be yes, the other 5 on the floor would be no, and no further action would be required. Did the resident receive direct care from a healthcare worker who was positive for COVID-19? So in this case, the answer would be no. So we'd go to the left, and in this question, the resident would meet the requirement of having close prolonged contact with a symptomatic person. So yes. And then this leads us to the far right of the flow chart, again, asking if the resident was vaccinated and boosted. So for those residents that are not vaccinated and boosted, again, they would be treated as a high risk contact. And then if they're vaccinated and boosted, yes, they would be treated as a high risk contact, but they would be able to be tested on day 5 and monitored for symptoms. And then again, if the test is positive, they would be treated as a case. And if negative, the isolation may be discontinued. So further to the point of trying to minimize the amount of testing, but also the days in isolation. So we can go to the next slide. So I'm going to go over some of the changes for admissions and transfers. And homes are to follow the guidance for the requirements and information on testing and isolation of any new admissions and transfers into the home. So we did aim to clarify this section particularly if the home is experiencing an outbreak and when consultation with the health unit is advised, and to assist with the requirements based on the various settings. So we did develop a similar algorithm to the one just shown, and Sarah's going to go over some of those examples for how the health unit and the home would use this.
Sure. Next slide, please. So the first scenario is that a patient is admitted to the hospital. The patient is stable and ready to be discharged back to their home. The hospital discharge planner contacts the long-term care home to discuss the transfer. What are some considerations to support the resident transferring back to their home? So we wanted to know if the hospital is an outbreak, and we discovered that no, the hospital is not an outbreak, and the resident has not been exposed to COVID-19 in the hospital. We know that we find out that the resident has been vaccinated and boosted. The home that they're transferring back into is experiencing an outbreak. However, it is limited to 1 floor or unit. So we do not need to consult the public health unit. The resident is asymptomatic and has tested negative within the hospital. So we'll go yes, they're vaccinated and boosted. So we would advise that the resident be screened on arrival and isolated until a negative test result from day 5 is received. So next slide. And noting that while residents are in isolation and cannot participate in group activities, again, as I mentioned earlier, the resident may be provided with chances for one-on walks or other activities to get out of isolation a little bit. Next slide is scenario 2. So a resident has been sent to an emergency department by ambulance. After they are assessed by the physician, it is determined they are not required to be admitted and will be sent back to their home the following day. So we know that the hospital is in outbreak where they were visiting in the emergency department, and they may have been exposed to a potential case of COVID-19. We know that none of those apply, I think. Yes. So consultation with the public health unit is not required, but however, given that they were potentially exposed to COVID-19 out of abundance of caution, they would be advised to be treated as a high-risk contact. So we would refer to the isolation requirements. If they are asymptomatic, if they have received their vaccination and their 3rd or 4th dose of the vaccine, they would be advised to isolate for 5 days and have a negative PCR test on or after day 5. And then isolation would be discontinued at that time. And that is the last slide from me. So I'll hand it back to Sam, I think.
Thanks, everyone. Is there anyone else speaking from the ministry or OCMOH teams? Otherwise, we can go to Q&A. All right, so I'm going to turn it over back over to the panelists to go through the questions that have been received so far. Remember to submit your questions. Please make sure you go to slido.com and use the code FCOFEB16 to share your questions. And now over to the ministry team.
Hi there. Are you able to hear me?
Yep, Nancy, you're coming through well.
Great, thank you. My name is Nancy Paroff-Johnston. I'll be moderating some of the questions. I'm from the Ministry of Health. My apologies for not turning on my video cam. I'm having some issues with connectivity today, and it tends to interfere with being able to speak and the video chat breaking up. So I'll be running through some of the questions that we have here, and we'll have our colleagues from the ministry try to answer some of them. So the first question I have here is, when will you be allowing unvaccinated into long-term care? And so have we got someone here?
Thanks, Nancy. Dawn Mallet here. I'm one of the directors of pandemic response for the Ministry of Long-Term Care. I see we have 3 questions up about vaccination, so might be good just to tackle all 3 in one answer. So just to continue about
Sure.
allowing unvaccinated, we have also about the vaccination passport for the province being removed, and will caregivers and general visitors still need to prove vaccination status to enter the home after March 1st? And then also, what is the vaccination requirements for essential caregivers? So the Ministry of Long-Term Care does have an immunization policy under a minister's directive. We updated it in January, where it does require for staff, student volunteers, support workers, and caregivers to have 3 doses of the vaccine by March 14th in order to enter the home. For general visitors, it remains at 2 doses. And that is still in place. We recognize that the province has lifted the requirements as of March 1st, but given the vulnerability of the residents, and again, going back to the transmissibility and trying to keep our staff and residents safe, we will be continuing with our immunization policy as has been planned. So that will answer the first one. With regards to unvaccinated coming into long-term care, you will have seen when Aaron was speaking that starting on March 14th, children under the age of 5 will be able to enter the home, and we completely recognize that they are not eligible for vaccinations at this time, and so they'll be our first group. The ministry is actively working with our system partners, including the Office of the Chief Medical Officer of Health, so Sarah and Danielle, who have joined us today, to also be looking at, what are we going to be doing forward, and will there be a point where we may be able to release or relax these requirements for vaccines? But at this time, we're not. And I'm going to turn it over to Dr. Sarah Erdman just to speak about vaccine efficacy and why we are continuing on this path for the long-term care sector.
Thank you, Dawn. That's a really important point to note. As you mentioned, we really want to protect residents from Omicron infection, and we know that 2 doses of the vaccine, even when 6 months from the second dose, which a lot of people have had, given waning immunity, it provides little protection against Omicron currently. So a 3rd dose is really shown to restore the protective effect of Omicron, of the vaccine for Omicron, to between 50 to 70%. That reduces the risk of passing COVID-19 on to residents. That means fewer people infected within long-term care homes, fewer people having to isolate. And so that's really an important part of our public health measures for long-term care homes.
Okay, thank you, Sarah. So I'm wondering if we could move to the next set of questions. What is being done about the continuous testing? Oops, sorry. This is jumping up here. Okay, so let's look at this. What is being done about the continuous testing? If a resident leaves, they are required to have an antigen test and a PCR test on day 3 and 7. And I'm not sure if the other questions below. How is the information conveyed to long-term care homes? I was contacted by a loved one this morning, and long-term care said they were not aware of any changes to visiting restrictions. So this is more about how we communicate this information to long-term care homes. So maybe we can start off with the continuous testing question, and what's happening around that, what's being done about continuous testing if a resident leaves and they're required to have an antigen test and PCR on day 3 and 7.
Thanks, Nancy. I'll start off and then can turn it over to see if Sarah or Danielle have anything further to add. We did make an update in our most recent guidance document that came into effect on February 7th, recognizing, again, just the balance of the amount of testing and now our further understanding about Omicron and its transmissibility and the severity of it. So for residents who are going out on day absences, we've actually changed it where they'll be tested on day 5. And there's no isolation requirement for the resident going on day absence unless they are known to have come in close contact with somebody who is COVID positive. For those residents who are out of the home, 5 to 7 days a week, so regularly out of the home, may it be for dialysis or for some other purpose, then we'll be looking, and this is pretty consistent with what we've had in place, looking at the homes doing testing on 2 days in a week and trying for consistency there. So if testing every Tuesday and every Saturday, as an example, just to make sure that we are catching if anybody is COVID positive when they're in the home. Sarah, I don't know if you have anything to add to that.
Yeah, just to add that we are continuously reviewing our policies and our recommendations around testing, given the emerging science, and especially given that the rates are decreasing within our community. And that's the most important. We do this to try to prevent COVID-19 from coming into the home. And so as rates in the community decrease, that will definitely be able to be scaled back as quickly as possible, recognizing that there is a significant burden for those who are continuously being tested for these reasons.
Okay, thank you very much. I think we can move on to the next question. And this is around oops, this is jumping. When will residents be able to be away on vacation? And this is for a 7-day vacation or more than one night.
Thanks, Nancy. So within our different documents, we define different types of absences, and one of them is temporary absence, which is basically going away for the home for at least 2 days and includes an overnight absence. We don't actually specify in our documents as to how long they may be away for that time. So once residents are able to start going on what we call the temporary or the overnight absences, the ministry isn't restricting to the length of that absence. We would encourage residents and their family members to work with the homes to talk about the home's own policies and see when that might be something that the residents may do. I will just add, the longer that somebody is outside of the home, the increase in risk of transmissibility of Omicron as well. And I think I'm just going to, I think there was a question that we kind of jumped over actually answering that Nancy, you raised last time about just notifying the homes and how our homes made aware of our changes. So we do release all documentation to the home. We share with them a memo as well as updated documentation. And usually this is actually done in advance of sharing it with the general public. And so the homes all should be already aware of all of these changes and what changes have been put in place. We also will be holding a webinar for the homes themselves tomorrow to make sure that everybody is aware of the current plan with regards to the 3 steps of the measures. I know previously we've had a lot of questions, and we met with residents last week who asked questions themselves about just, who can put on these measures, and what if a home wants to do something stricter than what the ministry or what the public health unit has put in place for themselves. And we really are encouraging homes to be working with the public health unit if they do want to put in place a restriction that is greater than what the ministry or the PHU has put in place. But we're also encouraging the consultation of the residence council and the family council when they're doing so, and that just kind of recognizes that the home risk tolerance may be somewhat lower than what the residents or the families may be comfortable with, or maybe it's vice versa. And so just really trying to find that balance and making sure that the residents' voice is being heard when making these decisions. Nancy, I'll turn it back to you now.
Great, thank you. Thank you for that, Dawn. We did have that question up, and so I'm glad you had an opportunity to go back to it, and it's listed as the last one here. I'm going to jump to the middle question here. And this is from Christine. And the question is around how homes are able to address having to isolate a resident who has a roommate, especially if symptoms are present and they are awaiting a PCR test. So I'm assuming this is more around dealing with individuals who may be symptomatic, need to be tested, and they also have a roommate who needs to be isolated, and how that's managed.
Sarah, I'll turn that one over to you if you don't mind.
Yep, no problem. So typically, if a resident has a roommate and the resident is symptomatic, that roommate would typically be considered a close contact. Even while they're awaiting a PCR test, we would presume, or the public health unit would presume, that it is COVID until the PCR test is back. And so that both would have to be isolated, unfortunately, under droplet and contact precautions and protected. In order to prevent further transmission to other residents on the floor.
Okay, thank you, Sarah. Hopefully that has answered that question. I'm going to move to the next question that I see here from Cassandra. And this is a question around what avenues would be available to families and family councils if their home is not willing to relax measures in accordance with the new guidance that's provided by the ministry. And I think this is one of those issues that it may require a balanced approach with what's going on if there's an outbreak in the home, and pathways that they could raise concerns to various groups such as the ministry. So perhaps this is one of those questions, Dawn, you could talk a little bit about pathways for raising issues, and Sarah, maybe talk about why there might be discordance with what's happening between easing measures and a home.
Thanks, Nancy. So absolutely, as I mentioned in the last question, we are encouraging the homes to be working with the residents and the family councils and looking at relaxing measures. And again, it goes back to we're really trying to look for consistency across the province, so that everybody is able to do the same things across the province as it makes sense, recognizing that community spread may be different in different areas, and that's really where the public health unit comes into play. I think, if the home is not willing to relax the measures, then definitely a dialogue with the home to get an understanding of why they might not be relaxing the measures. Is it because the PHU has put in place greater restrictions, or are there other things happening within the home that might make the home decide that they should continue with stricter measures? If family members do feel, and residents, that the home has really gone just too far above and beyond, then there's always the MLTC action line that they can call in and raise a complaint. And just again, we are as a ministry very much promoting consistency, doing the webinars, sharing the information, and really working with homes, especially on the topics that we talked about today, with the visitors and the absences policies, and making sure that caregivers are always welcome into the home. Sarah, I don't know if you have anything else to add.
No, I think you summed it up perfectly, Dawn. I think that the recognition that different areas might have different rates, and so public health units might advise certain additional things. We work with those public health units to understand what they're doing, and we encourage them to work with their homes to really clarify what they're doing. But in terms of outbreak management, it is under their purview to do the investigation. And so potentially in certain outbreak instances, they would be putting on additional measures to protect the home from further spread of COVID-19.
Great, thank you both. I'm going to jump to the question that is at the bottom of the screen here. This is a question around testing, daily testing. Our home currently tests staff and essential caregivers daily over and above guidelines. So I think the question here is around whether the costs of these actually take away from resident care, or the costing of this care and where it might come from, the testing.
I'm happy to answer this one, Nancy. So the Ministry of Long-Term Care has specifically allocated funding for the homes with regards to pandemic response itself. And so none of the costs related to the surveillance testing would be coming away from any of the costs related to residents' care to pay. So hopefully that gives a little bit of comfort of that, you know, there is no funding decrease basically for the residents' care, and the purpose of the ministry's pandemic response funding is to make sure that the residents are able to receive as much care as possible, but also recognizing the additional cost and burden of the home for that the pandemic has put onto to the homes. And also just to the question, I guess I'll just go into about, you know, the home currently testing staff and caregivers daily. We hear that it's very common, especially once Omicron happened. And again, just looking at the risk level and the knowledge of the transmissibility. And so we do set aside minimums in our minister's directive, but homes are always welcome to go above and beyond the minimum that are in the directives. Thank you.
Thank you, Dawn. I think we've answered Cassandra's question here, which is number 2. I'm going to jump to the bottom question. When can residents, and under what conditions, can residents mix and mingle with each other and have no cohorting restrictions? So this might be more of a public health oriented question.
So we are looking at very shortly lifting the restrictions when homes are not in outbreak for cohorting restrictions based on positive case trends and decreasing numbers of outbreaks within homes and within the community, and decreasing cases within the community. That being said, within an outbreak, that changes the situation, and so that's up to the discretion of the public health unit. And so we encourage them, once an outbreak area and zone has been defined, that residents outside of that outbreak zone can safely, once the public health unit declares it safe, safely continue their activities within their cohorts. Though the residents in the outbreak zone would be under isolation until the outbreak is declared over.
Thank you, Sarah. I think the second question Dawn had addressed, but we'll bring this up again. Will there be any changes to long-term care directives when vaccine requirements are dropped on March 1st? So it might be helpful to just revisit this point again.
Yeah. Thanks, Nancy. And no, we're not changing the long-term care directives. We recognize that as a province, they are making those changes, but given the vulnerability of the sector and the higher risk for many of the residents, we will be continuing with our vaccine mandate and our testing policies as have been currently in place. As I mentioned earlier, we are always working with the experts and reviewing and looking at our policies and looking for, you know, towards the future as to what things will look like. But at this time, all of those restrictions continue, or requirements, sorry, not restrictions, continue to be in place. Nancy, I'm not sure if you've cut out or not, because you lit up, but I can't hear you speaking.
Dawn, maybe if you just want to speak to the residents going on vacation again, we had that question upvoted again. I know you had previously answered it, but.
Absolutely, thanks, Erin. So the ministry doesn't put restrictions on length of time that people go out for an overnight visit. So starting on February 21st, those residents who have 3 doses of their vaccine will be able to go out on overnight visits, or absences. And then starting on March 14th, Any resident, regardless of their vaccination status, will be able to go out on overnight visits. And we encourage families and residents to speak with the home as to exactly the length of the visit or the absence that the resident may be out on. There would be no restrictions from the ministry on that one. So assuming that Nancy has frozen on us, I think I'll just go ahead and ask the next question. And this one will actually be for Sarah. So one resident tested positive. Public health instructed home to isolate everyone who never had COVID-19 regardless of vaccination status. Is that correct?
So prior to the newest guidance, I don't know that it would be everyone in the home. It would be everyone within whatever the public health unit determines is the outbreak zone, or who their close contacts would have been, regardless of vaccination status, given that in December, there was significant, and there's still significant evidence that 2 doses of vaccine provides little protection against Omicron. So we did make that change. Current guidance, now changed, is that we would advise the residents who have been in close contact with that resident who tested positive to be isolated, and those who have been vaccinated and boosted their isolation would be discontinued after a negative PCR test from day 5 following the exposure. So we're really trying to help public health units to really narrow down the number of residents that are isolating based on their actual exposure to the resident who tested positive. But it is at their discretion. If there is significant widespread transmission within the home, then they might be declaring subsequent units in outbreak as well. I hope that helps clarify that question. Those who have had COVID-19 since December 20th and have tested positive would not be required to isolate or be tested unless they develop symptoms.
Thank you, Sarah. Sorry about that, everyone. I seem to be having technical difficulties. It's Nancy that's back on, so I'll continue asking questions. The next question here that I see is, can an unvaccinated essential caregiver take a resident to the doctors for an appointment?
Thanks, Nancy. So the ministry does not put restrictions on who a resident is with when they are in an absence, whether it be social or for medical, such as the example given here. We do recommend that residents be safe when they are outside of the home, and so wearing a mask, washing their hands frequently. We do recommend that they limit their contact with anybody who is unvaccinated, and so while it wouldn't necessarily be our recommendation to be going out with an essential caregiver who is not vaccinated, there would be nothing that would restrict that from happening from the ministry.
Okay, thank you, Dawn. I'm not sure if this question was, oh, we've got a changeover of questions. Moving forward, will entire homes still be declared an outbreak by the PHU if the positive cases are restricted to a specific home unit? So again, I think this is around declaration of outbreaks in a home.
Thanks, Nancy. Just to reinforce that the goal is to promote that public health units would not be declaring a home, like an entire home in outbreak unless there is evidence of widespread transmission. That being said, sometimes public health units given their risk assessment or their investigation might have reason to declare an entire home in outbreak. It also depends on the physical ability of the home to isolate different units from each other and declare an outbreak zone appropriately. However, we're trying to move away from that as much as possible. So there may be specific scenarios where that could occur, where there's widespread transmission or the inability of a home to isolate certain units. But that being said, for physical reasons, but that being said, that should be hopefully rare now.
Thank you, Sarah. And there's a question here from Deb that sort of ties with this. And it really talks to how the home that Deb is referring to is an older home. The families are having a hard time understanding what the restrictions are, learning what those restrictions are that are placed by admin and public health. So where can families learn about specific restrictions to the unique situation of that home? So it sort of ties into your previous response about outbreaks being a bit unique to the structure of the home, but also how can families sort of learn about what's applicable to that home?
So I'll start off with this one. Just, you know, the ministry is encouraging homes as much as possible to be communicating with the family and with the residents so that everybody can be of the same understanding. And so really working with the home and the PHU to understand exactly what are the restrictions in place, which may be unique to the home itself. For the ministry's guidelines and requirements, everything is posted on ontario.ca, and so everybody could go to the website and find the latest version on our website to see provincially what has been put in place, so that you can then work with the homes to understand, you know, what further restrictions may have been put in place due to the uniqueness of the home itself or the community spread within the PHU.
Okay. Thank you, Dawn. We have another question here. Is there a public health restriction regarding a fully vaccinated essential caregiver helping to feed a non-vaccinated resident who is in a group setting dining room? So this is somebody who is providing some assistance to residents, and that might include a non-vaccinated resident, even though they are fully vaccinated, if there might be any restrictions around this.
So we've really tried as much as possible, especially with inside the home itself, to not differentiate between vaccinated and non-vaccinated residents. And so if the essential caregiver themselves is fully vaccinated, then in a non-outbreak setting, there would be no restrictions to helping, but we would want them to take as many precautions as possible with regards to PPE, and of course recommending physical distancing as the resident themselves is not vaccinated. I don't know, Sarah, if you have anything to add to that.
Yep, that's correct. In a non-outbreak scenario, caregivers who are fully vaccinated may assist the residents with eating. They should remain masked, however, is what the guidance states. But yeah.
Okay, thank you. A couple of interesting questions here. And this may just be clarification of some of the policies. Can you explain the procedure when a resident leaves for the day and returns? Will he or she be isolated or just tested, and which test? So this may just be a day visit where they go out and return, and what would happen to the resident when they returned?
So our updated guidance released on February 7th has just the resident being tested on day 5, and there would not be any isolation requirements unless it's known that the resident came in close contact with somebody who is COVID positive, and then we would turn to the charts that Sarah and Danielle walked through today to look at how somebody who's been in close contact would be required to be isolated and tested.
Okay, thank you. The next question is from Michelle. Please clarify the parameters around going for walks during an outbreak on a residence unit. So what sort of precautions might be necessary for one of those individuals who may be on a unit where there's a declared outbreak, and they...
Yeah, I'm happy to do that, Nancy. So the resident who is on outbreak measures, so they would be advised, or we would advise that it would be at the discretion of the public health unit to ensure that IPAC measures can be maintained. the essential caregiver or the loved one, the visitor, or the staff member who is going on a walk with the resident would be advised to be in full PPE because the resident could be infectious. So that would include an appropriate mask and eye protection at minimum. And then we would advise that the walk be taking place when the resident would not be in contact with any other individual. So in an empty hallway, for example. So I hope that helps clarify.
Okay, thank you, Sarah. I think we're just going to answer a couple more questions given that we're running out of time here. The first question here is that our long-term care home recently said that family dining would be reinstated. What does family dining mean?
So I'd recommend speaking with the home to understand specifically what family dining would mean. There's different terms used throughout the sector, so it's not one that I'd want to give a specific answer on because it might vary based on the home itself.
Okay, thank you. And then the last question here is really around cohorting and being a bit confused about the cohorting piece. Their understanding was that as of now, cohorting is not required and it's only required when there is an outbreak. Sarah, maybe you could come back to this piece about when cohorting is actually required.
So I'm happy to answer that and clarify. So according to the long-term care guidance, residents should be cohorted in small groups with consistent membership during high-risk activities, so singing and dancing, and organized events and social gatherings should be limited to no more than 10 individuals at a time when homes are not in outbreak. However, that is something that, given decreasing rates, we will be reviewing closely. So that's when homes are not in outbreak.
Okay, thank you, Sarah. I think at this point we've only got a few minutes left, so we'll be stopping the questions at this point, but would like to wrap up. So I think, Sam, I'll hand this back to you.
Thank you so much, Nancy, and thank you to everyone else who presented and spoke today. We, as FCO, we know that this is a really hard time for folks. Understanding changing restrictions, changing measures, perhaps sometimes the information you're getting from the home versus public health versus the ministry and so on can be quite confusing. So thank you for joining us this morning to get a better understanding of the restrictions, the changes that are coming, the measures that are being put in place, and the intersections between public health, home rules, and the Ministry of Long-Term Care directives. So thank you to all of our presenters, speakers, panelists this morning. A big thank you to Nancy for her facilitation of the Q&A and dealing with technical challenges. And a reminder that further questions can be directed via email. And that is mltcpandemicresponse@ontario.ca. So mltc pandemic response, all one word, @ontario.ca. If you have any other follow-up questions, you can direct them to the FCO team, and we will help you to access the correct information. We know there's a lot of misinformation around vaccination effectiveness and efficacy out there, misinformation around other things related to the ongoing pandemic. So we encourage you to reach out to us for assistance and support and use reputable sources of information. We can only get through this together by supporting our fellow person and using the best available information that we have. So on that note, we're going to wrap up this morning's session. We thank you again for your time that you've taken to be with us as attendees, presenters, and on behalf of the entire FCO team, I thank you all again and wish you a good rest of your day and to be well, stay safe, and take care. Thank you so much.